It looks like orthodontics is finally beginning to ask physiologic questions rather than simply dental questions.
Is the impact of different rapid palatal expansion appliances on sleep, nasal airway, resistance, and dentoskeletal dentoalveolar characteristics. A prospective randomized controlled trial. What were the issues or what were your thoughts?
I was really happy to see an RCT that actually measured airway physiology. I mean, I thought that was one of the big points.
Is the missing link. Welcome to Breathe, Sleep, and Smile, where our breathing, sleep, facial growth, and health connect. This is the airway conversation beyond buzzwords and connecting the dots that are often missed. Richard, how are you?
Hey, Mark, I'm doing great. I'm up here in Seattle and I'll be joining the podcast tonight from my hotel room.
Great. Well, I know it's been a while between both of our schedules, kind of crazy trying to coordinate. I think we've missed 2 or 3 weeks, but here we are. And well, tell me a little bit about why are you in Seattle?
Well, actually, I decided to take an orthodontic course that focuses on the health of the dentition, and that's how it's advertised. It was a 5-day course, 10 hours every single day. Got off a little early today, but got to see and hear the perspective of other clinicians and their approach towards, I'd say, common ground, but not a common approach, if you know what I mean. But it was great to see how people think about all this, and where also where there may be some gaps, and also from a teaching standpoint, where things could have been done a little bit better. So it was very enjoyable for me to be on the other side of the podium for once, and really get to see the highs and lows, the struggles of educators trying as hard as they can to get their ideas across. So that's my story. I'm not going to name any names, but it is in Seattle. And
Yeah, no, that's great. That's great. Tell me a little bit before we launch into like our
yeah,
main topic here. Tell me a little bit about what did you garner? Because we're here talking about airway and
right.
general wellness as it pertains to that. The role of the dental provider way beyond treating the teeth. But in this course and with the instructors, without naming names and all that, and
Sure.
tell me a little bit about what you thought about as an educator, because our role here is really to do the best job in educating. And for you, what are your comments about that whole
Well,
experience this last
I,
week?
first of all, I thought both of the presenters, the clinicians, are very very high level clinicians, very very knowledgeable, very well meaning, but from a pedagogical standpoint, I think they missed the mark a little bit because they used a lot of information. Rather than parsing it out carefully and building on things, it was a little bit disjointed. It was kind of interesting. The interplay between the two speakers, they would actually sometimes contradict each other and have these really polite arguments during the course. And I think that was kind of interesting. But just the sheer volume of material was too much. And as you need to put a slide up and let people really observe it and understand it, and then you talk to it and you ask questions about it rather than flipping through the slides, sometimes as little as the slides were up as little as maybe 2 seconds or 5 seconds, and click click click. And if for me, if I put a slide in my deck, I'm either going to delete it or I'm going to show it, and if I show it, I'm going to make sure it has a purpose. So I think a lot of it was just too much information, and maybe they had a hard time deciding what they were going to teach. I don't think the learners in the group, there were about 20 people, most of them did not have the level of understanding about airway that I've been fortunate enough to learn, thanks to you and in my journey. And I think a lot of this kind of went over their heads. Also, to be critical. I don't believe they had an airway focused approach. It was more like airway was it was part of everything, but it wasn't the primary part. It wasn't the first thing you look at. It was sort of an afterthought at times, not always, but at times. And I think my conclusion is, Mark, we do a lot better. And I think that when people left the room, they were impressed with the knowledge. They were impressed with some of the cases that were shown, but I don't think that they had a very good pragmatic clinical ability to move on. In other words, I said it may have been transformational, but it wasn't translational. And one of the things you were mentioning earlier when we were talking today is that, truly brilliant educators take complex topics and make them in a more understandable and something you can build on.
Simple and understandable. Yeah.
Agreed.
Yeah, so do you think on Monday, whoever attended the course after a week paying whatever tuition, would they be able to execute on this information in a meaningful way?
No, I don't. And I think that was probably the biggest failing thing, is that most of the people I talked to said, "Oh, this is very interesting, but I need to learn more." And even to the extent of wanting to take the courses that these speakers offer in their private teaching institutes. So to actually figure it out, it's like, okay, great, you give me a 5-day intro. Now I need to really learn how to do this and how to really apply it in my practice.
Yeah, so that, that really speaks to the challenge, certainly, that I've been going through the last, 15, 17 years, is getting a rather complex topic. And I think I've learned from fits and starts, it's like, how do you teach this so that you can actually help your patients, your community? How can you actually do this beyond just it being an expensive hobby, if you will, where you actually can scale the efforts? And of course, with the Airway Nexus, that we've launched that fellowship, it's based on 15 to 17 years of learning how to teach a complex topic. And on the one hand, I'm very excited that you were able to go to a course that's actually talking about topics that I was lambasted for 10, 12, 15 years ago,
Right.
to where now this is it. But then now for that provider, how can you help your patients? There needs to be a system, and that's where the Airway Nexus comes in. And at the end of the day, you actually have to be able to do it with the patient. So I appreciate the problem of these individuals at the podium trying to share their experience. I garner that they didn't really have a deep understanding that went beyond just dental treatment, which is what we do, right? This is the way we're trained. Treat the teeth, expand. But that's not what airway-focused dentistry is about. And, not a right or wrong, it's just an is, right? And I think we as a profession are going to work through this. And thanks to you and being able to work with you, I think, you're going to help us really be able to translate it to where it's meaningful for that clinician that takes time out of the office to learn something, to be able to help their patients. At the end of the day, it's about the patient. It's not even about the dental provider. It's about the patient, right?
Absolutely, 100%. I
Yeah, I know.
there were I think 4 orthodontists in the group, and I'm not sure how much they're going to change either, which I thought that was kind of interesting. And also, a lot of the information were presented from a non-U.S. perspective too, when it comes to third-party providers and the different systems of healthcare around the world that need different levels of proof for things to be green lighted. So that was a lot of time was spent on that, and I was like, God, this is kind of strange because they weren't really speaking to the U.S. system, and yet everyone in the room except for one was either U.S. or Canada. So I don't know. I think people can be very impressed with cases, and if you attach, it's sort of like if you attach the term airway to it, and you talk about a screening form, and then you show a before and after AHI, that's airway, when in fact that's not. That's just that's part of it. And I was a little bit I say disappointed that the topics of upper airway resistance syndrome, of inspiratory flow limitation, of looking at patients differently from their phenotype, none of that was really pushed as the first interaction you would have with a patient, and or understanding their symptoms beyond just phenotype either. That, which I thought was kind of interesting. Yeah, it was kind of good to be here. Expensive, by the way, but good to be here. And I think ultimately it'll help us even more in our airway nexus, just by knowing what might be being said out there. People that are making a claim that they're teaching an airway-focused dental approach, and yet it wasn't quite. It missed the mark a little bit. As much as I thought it was wonderful and the knowledge was actually good, it wasn't the depth of knowledge that I think even our AMR 1 and 2 graduates have. It wasn't at that level.
Right.
Oh, anyway.
One last question.
Sure.
I mean, how much of it was about sleep dentistry, and how much was it about sleep breathing?
Wow. I think it was mostly about sleep, and even the tests, the device they use to measure airway function, it was more about sleep, absolutely, and less about
Yeah,
breathing.
interesting.
Yep.
So, well, I mean, as we've heard the saying goes that McDonald's didn't go out of business because Burger King opened a shop across the street, right?
That's right.
So everyone's jumping in now, right? And
Right.
that's exciting. That awareness is coming on, but more importantly, the grassroots, the patients, the moms coming in, parents, patients understanding that there's an alternative to CPAP and oral appliances. And that's really, I argue, where dentistry needs to go. And so with that, let's focus on and transition towards, our topic today. And you'll be able to see on the title slide that's, shown up here, that we're going to be talking about a study that just came out last month, which the title of it is The Impact of Different Rapid Palatal Expansion Appliances on Sleep, Nasal Airway, Resistance, and Dentoskeletal Dentoalveolar Characteristics, a prospective randomized controlled trial. Now, I know you read it, and any comments that you have before we kind of launch into like a robust discussion about it?
Uh,
What were the issues, or what were your thoughts?
yeah, it's a
Top,
study done.
top line thoughts.
Right, study done out of Turkey, published in the European Journal of Orthodontics. You're right, May 2026. Uh, I was really happy to see an RCT that actually measured airway physiology. I mean, I thought that was one of the big points. It looks like orthodontics is finally beginning to ask physiologic questions rather than simply dental questions. I think those are pretty strong statements, but I think that really is important. I like the fact that they measured rhinomanometry. They looked at nasal resistance, skeletal changes. Not bad. I mean, I think it's a major step in the right direction, quite frankly. And I was I take my hat off to the group. It's not a perfect paper, and we can digest it and or
Sure.
dissect it, I should say. And then, but yeah, I overall I think it's one of the pieces of literature that will be cited a lot in the future, because it speaks to something that, my gosh, Mark, you've known for a long time.
Yeah, I mean, I'm also excited, and this is great. Again, people are jumping in, and we're going to learn in there's a jagged approach. It's not like this linear approach to learning about this very complicated topic. And I think what I liked about it is that there's so many people now jumping into understanding that the midface deficiency that can be decompensated, if you will, at least transversely with rapid palatal expansion, whether it's surgical or whether it's with MARPE, with TADS, or just dental expansion, has a benefit to the overall health.
Right.
The conclusions saying that there was really no direct evidence, to me, kind of speaks to the lack of understanding in a siloed, very reductionist, evidence-based approach that doesn't really understand the problem. I mean, it's the way we were trained.
Okay,
But
now what do you mean? For the people that are looking at this paper, what do you mean by that in terms of the reductionist approach and the this you're speaking about this programming that we have about evidence-based
yes,
dentistry and how we have to make conclusions that are reductionist in nature. Can you explain that a little bit to everybody? Because
yeah, absolutely. Thank you. I mean, really good question. So, a really well-run study that would be considered good evidence would be one that controls all variables, and has an understanding of the potential confounding variables that may dirty the data,
right.
to draw conclusions that would be a result of the study. And so you reduce it down, like drug A versus drug B, with this particular population, with this gender that's matched to these ages, to kind of control, this level of education, inclusion, exclusion criteria. So you're trying to control the variables so that what you conclude is pretty specific because you reduced it down. So
And
that's what I mean
defensible.
by
And
reductionist.
defensible,
And
right? I
that's
mean, yeah, it's defensible too.
defensible. It's
Yeah.
classic.
Right.
It's
There is
classic,
like,
classic.
and as a result, they have to really, it's their N was only 45. They only looked at a small age group and over a short period of time. And that's kind of what evidence-based approach has done to science, is it's made it that way, right? To a certain extent. I mean, how could they
Right.
how could they have done it differently and even got it published, right? I mean, what are the editors of the journals looking for? And I don't imagine
Well,
this
that
article was easy to publish either. I'll bet it required a few rewrites and bounce backs from the editorial group that read it. I would guess, knowing
Oh no, and I could tell you as an editor, section editor
right.
of journal and a reviewer of different journals, I could tell you exactly that, and that's where I struggle. So historically, if we go back to how we practice dentistry, like when we went to dental school, it wasn't until really the late '90s, early 2000s where we started even talking about the evidence-based approach. Before that, if you remember, it was kind of like in my hands mentality. You had a
Sure.
mentor, an apprentice. This is the way you do it. This is the way you hold the instrument. This is the material you use. This is what you control to get the outcome. And that's
Or it
all
was
fine and good.
a lab study.
Right.
Yeah.
I
I
mean,
mean,
but even
yeah,
clinical practice technique, it was very technique.
sure.
We in dentistry essentially have run outpatient surgical centers where we have procedures that are, somewhat calibrated, right? The criteria or principles of surgery. You isolate, you get a medical history, then, you go through the whole thing, you isolate, you make the incision, you do whatever you're going to do. And these are best practices. And every would hold the instrument different or use a different instrument. They name instruments after themselves, and then they have the outcome, right? So
Right.
you may have different outcomes using different techniques, which that's not really what we want. We want one predictable outcome using one technique. So we did that for, the vast majority of our history in dentistry, also in medicine. And it wasn't till, Sackett and from McMaster University came up with this concept of evidence-based medicine. He wrote a book, wrote a policy statement that was then adopted by medicine and then later by dentistry, saying that we have to really look at the literature, the evidence, if you will. We have to look at the clinical expertise, how long you've been doing it. You have to look at the patient preferences. So it's this triumvirate. So that ushered in this era, if you will, of evidence-based dentistry. And what we've recognized, and it's served us well, is that it reduced things down to questions down to very simple questions that didn't necessarily allow us to make good decisions about complex situations, whether it's temporomandibular disorders that are very complex, many factors, where you couldn't reduce it down. James Fricton wrote about that, basically saying evidence-based decision-making makes sense with simple, reducible problems, but when we deal with complex problems, it breaks down. So it's not the construct to use to make those decisions. So now in Europe, through a number of different formalized movements like ICHOM, International Consortium of Health Outcome Measures, basically are saying we need to really look at interdisciplinary treatment, looking at human systems theory, what's called bioregulatory systems medicine. Recognizing that at any moment when we're treating a patient, you have to consider what's happening at the molecular level, like TNF-alpha, IL-6, high sensitive C-reactive protein, right? Those are the things that are causing problems at the cellular level. And then you've got the tissue level. Well, we're all trained to treat patients at the tissue level, what we see, not really recognizing what's going on underlying at the molecular level. So human systems theory is saying you got to recognize all three. So when we're treating a patient, things are not always intuitive. They're not mechanical. And so I think we're now ushering in this new era, and this is where airway-focused dentistry comes in. This is where people struggle. How can a kid, for example,
Right.
that is not breathing well have anything to do with bedwetting? How can a kid that is breathing through their mouth have a problem with recurrent earaches or with ADD, ADHD, or metabolic problems, or cardiovascular problems? So these are the problems that people aren't connecting the dot, and yet at the end of the day, we ought not to be thinking about just the structure. And I think what makes a truly airway-focused approach is that we recognize that we're looking at structure, function,
And
and
behavior.
behavior. So going back to the study, some of the challenges that I would push back on is the tendency to reduce it down to structure, really understanding that it's not just the size of the airway, it's also the condition of the airway and the function of the airway. So you can argue till the cows come home about whether it's an Hyrax or whether it's a Marby or whatever appliance is that's mechanical that we're used to arguing about in the dental orthodontic literature. But honestly, it's immaterial.
Yeah.
It's really low brow science. That's why medicine doesn't pay attention to these studies. I'm here to fight for our profession to really understand more the medical comorbidities and how, if you expand the palate, what that really means. So this is one of the issues I had with the study, and I can go on, but I'm going to take a breath and let you comment.
Okay, wow. But you know, how do we advance as a profession if we're in this situation where the RCT is the best paper, and then the only thing better than that might be the systematic review of several well constructed RCTs. Are you talking about moving to more like scoping reviews, or are you talking about a major change within the entire philosophy of how we look at things, how we research?
Yeah, no question. Bioregulatory systems medicine is the future, not this reductionist approach. And I would say randomized controlled trials are great when you're comparing drug A versus drug B, technique A versus technique B. The questions are surrounded that, but evidence-based thinking rarely asks about prognosis. It rarely asks about, the patient experience. And at the end of the day,
True.
we're all healthcare providers. We're beholden to the patient experience, right?
We've talked about
We're really beholden to.
Yeah, I was just saying we talked about that in one of our previous
Right.
podcasts. Yeah, and
Yeah.
so,
It's got to be tangible to the patient.
right.
Who cares if what we were trained says that this tooth has to be in this relationship with that, and if we do that, we're successful, if it means nothing to the patient, because they have no idea. Or an intermolar width of X is what the goal is, and the patient has no idea what that means. What we're beholden to is, how's the patient breathing? How are they sleeping? What medications are they on? Do they have all these symptoms? So I think, like, even with this paper, I hate to say that it's orthodox thinking in that I, as an editor, would reject it. I wouldn't have published it because they're looking at a three-dimensional problem, and they're talking about a three-dimensional problem. Yet in their material, they're using cephalometry, which is two-dimensional. So there's already a major threat to the internal validity of the study via the materials and methods.
But they did measure.
I acknowledged it.
Yeah, they did. I mean, they
Yeah.
showed improvement at AHI, which is another issue. They looked at
Yes,
rhinomanometry.
that-
They showed better, but they didn't ask, did the kid feel any better? They didn't ask if
right.
if it was there some improvement in
Yeah.
other symptomologies. So you're right, absolutely, totally agree. It was basically three widgets being compared. A bonded
Yes.
Mera RPE, a full bonded all the way to the midline, but over a bonded procedure versus a MARPE. And it's pro MARPE. I mean, MARPE won. MARPE was victorious. But you're absolutely right. The bottom line is, it was a little bit like the course I had this week. It's just sort of said, oh, this patient came in with an AHI of 4, and then they left with an AHI of 1 or whatever, and therefore, look how great this is. And also, they could breathe better through their nose. And so, but that's the end of it. They don't really go into what does that really mean. And did they ask any of these 14 to 17-year-olds any other questions about their fatigue, about any of their other symptoms, and what symptoms they even had going into it? Those weren't even discussed, right? We don't even know what condition these
Exactly.
That's it.
Exactly. And then how do you measure? Right. And exactly how do you measure
Well, we know how to
how
measure.
well you're breathing through your nose? I
We
mean, it's
Yeah, but we know how to do that. We know how
well,
to
yeah,
measure.
certainly.
Yeah. Go on.
I mean, you could use rhinomanometry and we feel good, but if the patient feels no difference, I it's questionable. And
Yeah.
then the big argument was about the angle of the liminal valve, the external valve. And yet, in the title side slides that we will show here, I have some images of some studies going back to the mid to late 80s actually showing that opening up the liminal valves actually decreases nasal resistance. And most importantly, what effect does that have? What it does is it downregulates the sympathetic drive. I mean, again, we're getting into the physiology. And you can actually measure that, which, by the way, that's what we teach. That's what we measure. Those are our outcomes to correlate with the qualitative patient experience, saying that my anxiety has gone away. I'm
Right.
not snoring. I'm sleeping on my back. I'm feeling better. My memory's better. I can function better throughout the day. Those are the tangible outcomes that we as providers should be measuring, not what appliance measures what palatal expansion. The problem with that is that I think in the paper, if you remember, I mean, you can, like with the Hyrax, you can maybe widen the palate, but oftentimes that's artificial and you're tipping teeth. That has nothing to do with airway. It just makes us feel better. And so I think the good that comes from this study is it starts a conversation to say, really, what should we be measuring?
Right.
And I think when we start going down that path, when we start really recognizing that we can, downregulate these cytokines, that we can actually measure it, even if it's in uh, an academic environment with ELISA, which isn't something that an average clinician would do, but that confirms that we've actually improved the health of the patient. To go along with the patient's also qualitative experience, that's airway-focused dentistry. And that's what we teach, right? I mean,
Right.
it is radically different from anything anyone else is teaching. I mean, for 15 years, it's like people go out, I mean, even people I've taught to go out there and go, yeah, they're expanding to a number, or this is the best appliance, and they have beautiful cases to show, but they're not saying anything about the patient experience. And
Right.
we are beholden to the patient. And I believe that, and honestly, medicines also has this problem. So I thought the paper was interesting.
Yeah. And I mean, I think overall it's positive. I think it does. I mean, it's a good paper for us to review in the Airway Nexus because we can also point out all the things it doesn't do and how our students can look at papers critically. It's like we talk about structure, function, behavior. What did they do in this paper? They dealt with one of those three objectives, just one, and then they looked at some measures. They saw improvements, and they could make some comparisons between the different types of expanders. But there was no discussion about behavior or function. There wasn't, and the thing that's really you and I know that if you structurally treat a patient to great numbers, whether it be expansion numbers or initial AHI numbers, and you get all this great data in 3 months, that's okay, but it's not the whole story. And the fact that the palate is wider are they just assuming that the patient's naturally now going to adapt a tongue posture that's different? Are they
Right.
um, is
Right.
right? I mean, that's
Exactly.
a huge one. And then if they don't, they're really not going to have a long-term benefit. They'll relapse. We already know that. So people sometimes just say, and this is what I'm hearing a lot from the expanding groups. And I've been to several expansion courses, shared my experience courses. And like you said, they're really cool in the sense that, wow, look at this result. It looks beautiful. Or look at this. They're only looking at AHI, all of them. Trust me. There's no discussion about, autonomic dysregulation and many other things. But
Raras and microarousals, right?
yeah, I mean, right. And then they just say, oh, and then you have to do myo. And this is like, it's almost, it's like they're throwing that out there almost to sound like they're being complete in the approach, but it's so much more complex than that. So, when you stage the myo, what does even myo functional therapy even mean, to address issues with function and behavior? So I'm in agreement with you on that, but I do still think that in its approach of being reductionist evidence-based dentistry, it may have been rejected by Dr. Cruz, but I think it's going to help our cause, and I do, because it is evidence that will find its way into an airway-centered, airway-focused approach, I think.
Yeah, I think honestly, no, I think it's evidence of how we ought not to think, to be honest. I mean, it's
Okay.
evidence of business as usual, right? I mean, I don't blame anybody, but honestly, I will robustly would talk to the authors and saying, you're barking up the wrong tree. And not disrespecting them, but just to say, look, we have to do things differently. And let me read the conclusion of the study and let's talk about that if we can.
Okay.
So the conclusion is RPE, rapid palatal expansion, treatment decreases AHI, the Apnea-Hypopnea Index, and TNR, total nasal resistance. So let me repeat that again. RPE treatment decreases AHI and TNR, approaching the values of individuals in the control group. In the MARPE group, a greater decrease in AHI was observed compared with the MMRPE group, which is based on the James McNamara criteria, which, by the way, was all based on cephalometrics. It's old data. It's James McNamara was a huge influencer, contributor to the orthodontic literature. I have nothing but respect for him. He's amazing, and no disrespect to him. He is very important, but I do believe what we know today, we think very different. So I just want to make that clear. So they're, again, looking at that there was significant increase in maxillary nasal width in the full coverage RPE and the MARPE mini implant assisted RPE group, while only the maxillary width increase was significant in the MMRP modified McNamara RPE group. So in the MARPE group, a greater decrease in AHI was observed compared to the McNamara group. Features suggestive of obstructive sleep apnea syndrome were commonly observed in post-pubertal adolescents with maxillary constriction. So a couple comments I'll make, and then maybe you can make it too. Number one, and you already said it, as they're looking at the AHI, which lacks sensitivity with this population. And if you don't really understand the physiology of breathing and sleep, you're going to just accept hook, line, and sinker the problem that sleep medicine is struggling with. That the Apnea-Hypopnea Index is a very coarse measurement of a physiologic process that makes sense for moderate to severe disease, which is the tip of the iceberg,
Right.
but is relatively meaningless for everybody else. So there was that. And then realizing that these individuals have they have more sleep fragmentation than obstructive sleep apnea. So if you're not measuring the right thing, your conclusions will be flawed. And this is the problem with sleep medicine. And the AASM, the American Academy of Sleep Medicine, has struggled with this. And a lot of it has to do with the third-party payer. The problem is so pervasive that the policymakers and those that come up with the medical codes really don't want to deal with it because it's going to be super expensive on the front end to deal with these patients. It's better to kick the can down the road and medicate patients through this population, but what it does is just fosters the next generation of CPAP wearers, which we already know is a problem. More chronic disease. So at some point we have to take a stand and not put our children on medication for a problem that's really a breathing problem. Understand that our modern environment has adversely affected the way our population has grown. The evidence is overwhelming, although it's been ignored. So I'll just say one last thing. So it says RP treatment decreases HI, approaching the values of individuals in the control group. Who is the control group? I'm going to argue that the control group is already diseased. They're just subclinical. So we're comparing a subclinical disease population with an overtly symptomatic population, if that makes sense. And I think many who are listening to this won't understand that.
Right. I was just thinking, where did they find this control group of these really healthy 14 to 17-year-olds? And what did they base their control standards on? What constituted?
Exactly.
Yeah.
Exactly.
Right.
So that's a problem. And if it's your child, I mean, I hear it all the time. Patients go in, have sleep studies, they're normal. And yet they are on Adderall and they may be high functioning. They may be 4.2, 4.5 high functioning athletes, but they're suffering. And so that's a different discussion for another podcast. But I think this paper is a good shot over the bow, basically saying we're starting to understand that there are things that we in dentistry can do to address flow limitation. But what I would argue is that the profession at large needs to understand what flow limitation means to the overall wellness of the patient, because there's a difference between not being sick and being well. And most patients here want to be well. I don't care how many supplements, how many peptides, how much you exercise. If you don't get the basics, it's an upstream battle. And that's what this podcast is all about, right? So
Right. Well, after your conclusion, there's not much I can say. I mean, I totally get it. I agree with you. I hope that somehow you and I and our team, and we do have some resources, can start to enter into some research and partner with facilities that can look at this at a little higher level. I mean, I think that would be really great. Um, Hopefully, that's something we can do in the future.
no doubt about it. And so let's end the podcast by maybe talking about it for 1 or 2 minutes about what we're up to. I mean, what is our solution, right? I mean, we could talk about this. What is our solution with the airway nexus and how we see the future? Can you talk a little bit about that?
Yeah, a little bit. I mean, I'm going to talk about it kind of from a mechanic standpoint. I mean, we have, thanks to Mark and Barry and their significant resources, knowledge, experience, we've developed a fellowship program that lasts for 1 year. It could be longer, it could be stretched out, but basically the fundamentals would be handled in the first 2 pillars. And then we have a large set of courses that are all more technique based, 7 of them in fact, which is incredible. That after you learn the fundamentals, you can start to learn the higher level application of those. We call that pillar 3. And then the fourth pillar, which is virtually unheard of. I don't even know where this could occur other than what we're doing. And that is an airway clinical study group that will have 9 sessions over the course of 1 year, that where all of the docs would be treating patients and monitoring them through the process. Unbelievable. I mean, it's 32 days. It ends in the award of a fellowship. And I'm really proud of it, Mark. I think we've really worked hard on this. It's a significant commitment in terms of time, et cetera. But if a dentist is looking for a way to transform their practice and the way they see their patients and treat their patients, what they can offer, I don't think there's anything better. For example, not to pick on this other course I just finished taking for 5 days, I don't think there's a chance that much change will actually happen. Maybe some eyes were open to the idea that I need to learn more. But as far as actually applying anything to a patient, I don't think that's going to happen. I really don't, even amongst the orthodontists that were in attendance. But that's not our story. Our story is one of being able to take these concepts and put them into play, see your patients, document them, learn how to take beautiful photography, see the improvements, see your failures, see your successes, understand from other people, not just your own cases, but you get to see everyone else's experience, how powerful that is. It's basically the study club approach. And in the end, provide you with the confidence and competence to be able to handle these cases on your own. And it's more than just in attending. It's also, we have Zoom conferences, 2 of them after every single meeting, plus the Airway collaborative connection and understanding how to. I mean, one of the big problems that I learned this week is that dentists don't know what to do with aligners with airway patients. And Mark, you and the Airway Collaborative, you've already solved that problem. So, I mean, that's all part of it too. It's this beautiful little gem that you've solved, is how to coordinate airway dentistry with aligner orthopedics and orthodontics. And it's such a plus. I didn't realize just how incredible what you've developed is until kind of seeing the frustrations of everybody in the room. So that's
Well,
my
thank you. I mean, I'm excited about it. And Rich, right before you got on the plane, we gave a 3-day course, right? It's the first of a 6-day course, right? And I could just tell you, and I know that you will agree with this because we were in there. Everyone there, and this is, by the way, very typical of everyone that's gone through the last 15 years, will say, they're sitting there and they're almost visibly stressed, some with tears, saying, this is my kid, this is my wife, this is my father. I see something I never saw before. I had some idea. What can we do? And in the breaks, everyone's saying, what can we do? I just can't wait. And I said, look, you've been living with this for a while. Now that you see it, that's great. And we could solve it. And we want to scale it to where you're not just treating your family, you're treating your community. We have to heal communities. And we have to bring in a lot of people into this.
Yeah.
The problem is too big for just us to do it, but we have to start somewhere.
Yep.
And this is the tip of the spear, but we really want to get it to where the entire profession is really looking in the mirror and saying, I need to do something beyond treating teeth, gums, and joints. I need to treat the patient attached to the teeth. And it's very compelling, very data-driven, very evidence-based approach. And I'm excited to really team up with you as a world-class educator that's really brought so much to the organization of the material, which, you saw this weekend, 5 days, and the material is great, but it's got to be organized so you could translate it so that the provider on Monday could start helping their patients. So
Agreed.
anyway, thanks, Rich. I think
bet,
it was a
Mark.
great discussion, and
Yeah.
I look forward to our next one.
Yeah, I do too. Thanks, Mark. Be well.
Yeah, thank you. You too. Take care. Bye.